Hi everyone, it's Bev Quee here from Neurotech. Welcome to the webinar for the InterX on behalf of ReaCare. InterX has been a really interesting device, and I've had a lot of success with it for both acute and chronic. So we're really fortunate to be able to have Katrina Lydiard from the Edith Cowan University. Now Katrina, as you might have read through the bio, is an OT who's had a lot of experience with the InterX, treating it for plantar fasciitis, tennis elbow, as well as chronic conditions. So I think you'll find this webinar quite interesting, and just understanding really the basic technology of the device, and then and how and why it's so effective in treating acute and chronic patients. So I'll just leave it to Katrina, and then there is a chat box there, so if you have any questions as we're going through the presentation, just type it into the chat screen, and then we can go through the questions at the end. So we'll probably save about 15 minutes at the end to go through the questions. Okay?
Okay, hi everyone. If anyone has any questions, when you send them up, maybe Harish can send them through to us, because we're not entirely sure whether we're going to see them on screen. And I'm not entirely sure, I think now that you're getting just my slide presentation. So as Bev said, I've had quite a bit of experience with InterX, and when I first started with it, probably 8-10 years ago now, I must admit everything about me clinically said that can't possibly work. How could it possibly do what it's doing? And then I was curious enough that I wanted to go looking further, so I've actually just recently finished an honours thesis, and it allowed me to go looking far more into the literature around it, and really that's a lot of what I want to share with you today, particularly the literature around TENS, because I guess TENS has had a bit of a bad rap over the years, and going back and reading it around my honours, I realised that there's a lot of excellent explanation in there as to why InterX is so effective. I gather that we've got in the audience a number of people who may have come across InterX or use it currently, and we also have people who are new to the device and maybe have never used it. So I'm going to try and give you a flavour of how it works and why it works, and for those who are familiar with it, hopefully it will reinforce what you know and maybe give you some other ways of describing it when you're talking to perhaps a surgeon you're working with or someone who isn't familiar with it. And for those that aren't familiar with it, hopefully it will give you a taster, but I'm very happy to answer questions and see if I can help you understand it further specific to your practice. I also believe that we've got a range of different professions. So while I'm an occupational therapist, I have worked with chiropractors, podiatrists, physios, OTs, even surgeons, people who have an interest in it, and I'm hoping that most of you will come from a profession that I may have already experienced some stuff with, so I can perhaps share those experiences as well. So we'll need to get underway and try and get through this part quickly. So my plan is to look at TENS and the history and why we have such a bad rap with it and what evidence there actually is of efficacy. Look at InterX, which I'll occasionally talk about as NIN, or non-invasive interactive neurostimulation. This is a more generic term for the device, and you'll see at the bottom of the screen I've also included a couple of other names that you might have come across before, but InterX works in a slightly different way. It's been set up in a way that I think makes it very easy to work, so I'm hoping by the end of this you'll recognise why InterX is particularly helpful. Then some of the evidence that we have got for InterX and its efficacy, some of the basics about how we use it, and then we'll have a good chat at the end hopefully about some of the conditions and treatment options that are interesting for you and your practices. So if we have a look historically at pain and TENS and how TENS was used, you'll see here Melzack back in 1975, so a long way back, and many of you will know Melzack and Wall as the creators of the gait control theory, so very well respected in a pain sphere. Melzack did a study with 53 patients who had intractable chronic pain. They tried all sorts of other things and exhausted all the options. They used TENS for 20 minutes 1 to 3 times a week, so nothing surprising there. But what he did that was different was he applied it to trigger points, nerve points and acupuncture points, and if he didn't get pain relief, he'd move them around and he'd try it on different trigger points, nerve points, acupuncture points, and he would keep going until he found the right triggers and got a response. Now, because he kept going and finding the response that he wanted, in these patients he was quite surprised that he got dramatic relief with them, but sometimes it lasted hours and even days, as opposed to what we always understand TENS to be, it works while it's on. So this was one of the first instances where it was seen that not only could we interrupt the nervous system and what it was doing in pain by putting another signal like a TENS signal across, but that perhaps there was a neuromodulation option here, and perhaps we were actually changing things going on because it had a lasting effect. He also saw cumulative reductions over subsequent treatments, and for 50% of patients there was a benefit 6 to 18 months later. So that's a really significant flow over, which really only happens if you've got neuroplastic changes going on. So to me, this, when I went back and reread this article, it really gave me a sense that a lot of what we know about TENS is perhaps founded on the efforts that have been made with TENS, and maybe there was a better way of doing it, and he seemed to have produced some results that we weren't expecting. He found obviously that correct electrode position was a big part of that. So then if we come forward to 2009, and Walsh, Howe, Johnson and Sluka did a meta-analysis on TENS in acute pain. So they specifically chose acute pain patients. And I won't go through too many of the details, but they obviously looked at a large number of studies and came up with 132 that they felt were relevant. So it's a fairly big meta-analysis. A lot of them, the TENS was given with other treatments, and they found that it wasn't easy to extract the data in the studies and couldn't make definitive conclusions as using TENS as an isolated treatment, so without other things. So in this study they certainly said, look, TENS doesn't seem to be great on its own, essentially. But then another group also looking around the same time, Bjordal and Johnson and Lundgren, did another meta-analysis, and they particularly wanted to look at the analgesic consumption rather than the pain response. And I think this is probably a more useful one and produced some very interesting results. So they took post-operative pain as their model to work with. They took obviously a very large number, 21 trials, but 1,350 patients. They found in their discussion that past reviews had not looked at the treatment dose specifically, and they hadn't actually excluded the probable ineffective treatment dose. So what they were saying was, if you were taking a drug, if you were taking Panadol, for example, and you gave someone 1 Panadol when 2 was what was required as an effective dose, and then you said, gosh, Panadol doesn't work, clearly that's, you know, not something that any of us would accept, and that's what they were saying really the TENS literature was looking at. So in their review they found that the studies that they pulled out that described, if you see at the bottom here, strong or definite subnoxious, maximal non-painful, maximum tolerable, or a current amplitude above 15 milliamps, all of those descriptions, they took those studies and then they analysed those to see what commonality there was. So now if we have a look at their findings, there were quite a few really relevant ones. The first being reduced analgesic consumption, so 26% better than placebo, and that was across all trials. That's really obviously very significant. There was also a 35% reduction in analgesic when they compared it against placebo, so that was a significant one as well. And then the last bits down the bottom I've got here, which I think are really critical for us to consider, is there are no negative side effects found in any of these studies from TENS or what's called ALTENS, or another form of TENS. And along with that, getting less nausea and better alertness. So if we think about the population that we're looking at, acute post-op patients, less nausea, better on alertness and no negative side effects. If that was a drug, we wouldn't question it. So we really have to start sitting up and taking more notice of TENS if we think about those things. So overall their findings, that TENS is greater benefit than placebo, that there is a dose-dependent effect. We have to consider a dosage and find how we can improve that dosage. The time involved in teaching, though, was a significant negative, a downside, and a reason why a lot of people didn't continue using TENS, and I think that's also important to note. And that we are able to increase self-efficacy, so getting our patients to take some degree of control over the pain that they're experiencing. And I guess any of us who've worked in pain and look at the current neuroplasticity perspective of pain, which I won't go into but I will talk briefly about later if you haven't heard it, any of us would accept that if you can take control of your own pain, your pain will reduce anyway. So that's a really important thing for us to consider. What benefit do we get by giving the control back to the patient? So all of that led me to think, yes, TENS is well worth revisiting, but we all know that if you've used a TENS machine anywhere along the way, it does come with some negatives and some things that make it harder. And I guess my argument here would be, if we want to find a way to make TENS more useful, we need to address these issues, and thankfully that's where InterX comes in. So InterX is different. It is a TENS, listed as under TGA as a TENS device by nature, but it's different in that the changes that we see are sustained, so range of motion, edema and pain, and in that even getting that reduction in pain, we're also reducing pain meds in some of the studies. Now, I know for TGA the listing is for pain, so I would encourage you to explore it from that point of view first, but I'm certainly going to touch on some of the really interesting stuff that I've seen and that I use it for in terms of range of motion and edema and scarring and all sorts of other stuff too, just so that you're aware of the kinds of things that I've seen and what we can use it for. So for those of you who haven't seen it, this is what the device looks like, and these electrodes one inside the other effectively. You can hear the device running across the skin, that's quite amplified, but we actually run the device across the skin without the need for gels, without needing to worry about moving it, which you would never do with a TENS device. The 5 things that I see it as being different from TENS, it's constant current with the concentric electrodes that you just saw, one inside the other. It does allow us to produce a high density current, so when we come across the area of activity here in the red zone, the current that can be produced by InterX is much more dense and stronger effect. The waveform's interactive, so we can see what's going on in the tissue and get feedback, and it allows us therefore to target where we're going with stimulation. So I'm just going to briefly touch on each of those. So constant current, any of you who know a little bit of physics, Ohm's law means that where the current is constant, so the device has constant current, as the resistance in the tissue changes, the voltage adjusts accordingly. So from that point of view, it means that we can move those electrodes across the skin. And any of you who've shifted TENS electrodes would know you would never shift TENS electrodes while the device is active. It's very unpleasant. But because of the way this device has been designed, it means we can move it across the skin and it's comfortable for the patient, and the signal constantly adjusts because of the changes in our resistance. If you know anything about accommodation with TENS, that is the tendency for the nerves to sort of block out a signal that they've been hearing for a period of time and that's very consistent and unchanging. We do tend then to need to ramp up TENS as we go along because it's not as effective or impactful. And this aspect, constant current and this ability to move the device and have it change, means we don't see accommodation in the same way with InterX, and that's a really valuable benefit. The concentric electrodes, you can see here with that red arrows moving, effectively those grey parts, the sections in the middle here and around the outside are your 2 electrodes, and the current will jump across at any time at one spot, and it'll jump across wherever the resistance in the tissue is lowest. So in essence, the device is already responding to change in your tissue. If you've got low resistance in your tissue, that's where the current will travel, and I'll explain to you shortly why that's important for us. But it does mean we get a bit of feedback as well. So if we look at the electrodes, the current is only travelling a really short distance in, and it means it's only getting about 3 to 5 millimetres into the tissue. Now, a lot of people, when I first started working with it, were questioning, well, how can it possibly do anything if it's only going 3 to 5 millimetres in? What we're looking for is an afferent-efferent response. So we're actually sending a signal up through the cutaneous nerve fibres, and we are therefore making changes through the central nervous system and back down again, which means that we're not necessarily just treating what's at that skin level. We're treating whatever the nerves themselves are able to stimulate or change, and that can sometimes even include visceral changes, so organ as well. So really deep changes even though we're only getting that signal in a short way. These concentric electrodes again mean we can move the electrodes across the skin while it's active. We can also identify where the current's travelling easily. We don't need conductive gels, so that makes it a lot simpler and less messy. And we've got, again, that accommodation being reduced by constantly adjusting signal. So then high density, there's a study that was done, it's only a very small pilot study, but it looked at InterX versus TENS, and the amplitude and the density was significantly greater in the InterX device. Now the benefit of that is if you're putting a high density current into the tissue and you're trying to have a conversation with the nervous system effectively, you're trying to talk to the nervous system and tell it, back off, don't need this pain. So that high intensity and density of signal means we don't have to worry about setting off a muscle contraction. We can put all of that current to good use. And I describe this often when I'm teaching at the uni. I describe this as with TENS, it's a bit like trying to get through a brick wall by this approach. We're trying to get across the skin and into the nervous system to speak to the nervous system, and we're doing it with a fairly ineffective device that we really have to ramp up. Whereas with InterX, it's more like doing this. We're punching through, we're getting communication going with the nervous system, and we can actually begin to affect some change. So really the big part about that is we can really get that amplitude up and not have discomfort. And all of the TENS research suggested that strong subnoxious intervention, that high amplitude, was an important component in success with TENS. So I believe that this is one of the strongest reasons why InterX is effective. We get it across the skin and into the nervous system really effectively. So now if we plug the device in, there we are, and look at it on oscilloscope, you might want to know what the waveform looks like. And I'm just going to see if I can get a cursor across. Yes, I can. So what we get is a spike and then a square pulse, and then it goes into a sinusoidal pulse that's damped down as it goes. So it's a pulsed biphasic damped signal. What the device does is it measures the distance here, and if you have a look again as this goes, you'll see that the signal, when we're over an area of lower impedance or less resistance and the current's absorbed in that stage where it drops right down, it also widens out. So if we have a look at that on here, this is an area of normal skin, and the device is measuring this distance across here, and this is where there's less resistance in the skin. The current can be absorbed and the wave itself stretches out, and the machine is measuring this distance here, and it's measuring change in that as well. So there's an algorithm in it that picks up what that distance in microseconds is, but also how quickly it's changing. And it's an incredibly intelligent concept because it then gives us feedback based on how quickly tissue change or nerve change is going on within your nervous system as you're treating. What it means though, we get on screen a number corresponding to this. So when we're over normal skin, skin with reasonable resistance, high resistance or high impedance, we get a low number, and when we get over an area of low impedance, we get sorry, did I just say a low number? Yeah, and we get over an area of low impedance, we get a correspondingly high number. The upshot of that is when you use the device, you need to go looking for high numbers. That's how we find these peaks in nervous activity, and I'll explain them in a moment. So all of this leads us to know that we can identify areas of low impedance and that we get that feedback, and it's telling us what the nervous system is doing, which is incredibly unique. We've not really ever had that kind of interactive opportunity to talk to the nervous system but then get the nervous system to talk back to us. We just have to understand what it's saying because it's a different language to what we're used to. So we go looking for areas of low impedance, and I'll just see if I can get this one running. Yep. And when you put the device on screen, you see the green number in the middle is what we call an activity reading. That reading goes up as we're going further down the back here, placing it further on and getting that 38. 38 is the highest number across this area, and I would be going for that area as an area of lowered impedance, and therefore an area where we can optimise our conversation with the nervous system. And I often describe that to people a bit like the picture I had of trying to get through a wall to get in and talk to the nervous system. What we're doing here, by picking areas of lowered impedance, we are finding windows or doors into our nervous system. So we're opening up an avenue where we can get in and we can really maximise the conversation or optimise our interaction with the nervous system. So those of you who've never looked into this before will be wondering, why are we looking for lowered impedance? And there are studies going back anything up to 40 years that identify areas of lowered tissue impedance on skin, any skin, but those are more intense depending on what's going on around them. So muscle trigger points or acupuncture points, which if you remember back, Melzack was identifying as really important sites to treat. And then also these active sites that several studies have identified. They haven't all called them active sites. That's a term that is often used with InterX. Essentially what these are is sites where following injury or surgery or in response to pain, we release pro-inflammatory cytokines. So we're releasing the chemicals that are designed to cause inflammation, and they're an important part of the tissue healing system and quite reasonable to have. But what happens at the same time is we get an autonomic nervous system response in that area. Now we all know that that results in sweat. So in actual fact, if you think about how electricity travels, wet areas or sweat are going to conduct electricity more easily. So these are our areas of lowered impedance. It's not rocket science. It means that we're looking for areas where in response to nervous system change, there is moisture from sweat, and therefore the current travels easily and gives us a window into the nervous system. So that's the background behind it. Now we want to just quickly look at some of the InterX supporting literature, I guess, the things that are really useful to look at, and perhaps to question whether these relate to some of the areas that the kinds of patients that you treat perhaps. And this study in particular I think is a really valuable one. It was done in 2010 and looking at bimalleolar ankle fractures, so really looking at patients who come post-op who had a predicted rate of recovery and path of recovery, and they took 60 patients, they gave 30 of them InterX and 30 a sham device, which obviously they saw as, as the placebo. And then they just performed 2 20-minute treatments in the day, each day, for the first 10 days after surgery, and they continued on with regular rehab for everything else in both groups. Now if we look at those groups, what we can see on here, these are the control group, and this is triangle to square is before and after these sessions or treatment. So before and after treatment, we expect within the day no change, and that's effectively what we're seeing in the control group. But we would expect a normal rehab process would steadily decrease their pain scores. The interesting thing is then when we look at InterX, we start with a score that's up probably similar or slightly higher level than the control group, but a 28% decrease in that first day. Now, any of you who've worked with patients day one post ankle fracture or any other kind of fracture and surgical repair, that's a significant drop. That's dramatic just in that first session. But what we see, and you will see this in patients that you treat with InterX, this drop then comes up slightly but never quite as high and continues in this stepwise fashion down until we get a significantly reduced result later on. And the interesting thing with pain is subjective. We can't avoid that. Using BAS scores is the best that we can offer in many instances. But the only thing that isn't subjective is when you get 0. And these patients in those last 3 days were absolutely getting 0, were approaching 0. So they reached discharge criteria well ahead of the control group. Now you might think that means that they were taking more pain meds. In actual fact, if you look at the total consumption, this is the treated group versus the non-treated group, and it's probably about 60% less. 60% of the amount that you're looking at with the control group. So it is significant reduction in pain meds at the same time as reduction in pain. We then look at the range of motion, and this one fascinated me when I first read this study, because in reality you don't expect something like this to have an impact on range of motion, and unfortunately none of the studies have identified exactly why. If anyone wants to do a study on that, there's a spectacularly good one waiting there. We look at total range of movement, and if you look at the control group, as you'd expect, no real change within the session, but over the period of time we've got this steady increase. However, again, if you look at this change within that first session, this is about 8 degrees. Now 8 degrees is a significant amount immediately post-op, and again we get this pattern where we're moving stepwise up so that eventually we're getting significantly improved range of motion. And it's fascinating to watch within a matter of minutes when you're treating someone with the InterX and you see their range changing before your eyes. It really is quite amazing to watch. And then the last one that's also quite fascinating is oedema. And again, you can see this happening with patients, particularly if you're treating hand injuries, something like fingers, where you've got very small circumferential areas. The reduction in swelling is dramatic, and you'll often see creases coming back in very rapidly. So like within a matter of minutes. So it's really worth treating people who have significant oedema impacting on their pain and movement. So again, this group is the active group versus, and they're dropping dramatically, versus the control group where you can see the more normal path that you would expect and that you commonly see. So that was a study that really made me sit up and take notice, and I started to look at particularly hand therapy patients, because that had been my background for probably a couple of decades in total, and really to see the kinds of changes that I could in hand therapy patients, it made me have to sit up and take notice, why was this device doing what it was doing. Another one that might interest some of you, if any of you work with total joint replacement patients, this is Total Knee Trial, and they only wanted to take people for the 3 days post-op. So they left them first day, the first 24 hours, and then they just gave them 2 20-minute treatments, the first time 3, the second, and 3 the third. And they, even with those brief days of treatment, they did see a significant change. So this is our control group, and this is the pre and post scores for those patients as well, for the InterX patients. So well worth looking at for immediate post-op. Now I'm only going to throw these ones up because these are results that have come from studies that have been done, very small studies, pilot studies, but studies that have produced really quite dramatic shifts, and I won't go into them in detail because it does take quite a while, but one of the studies in particular where they took blood immediately pre and post treatment and to see what happened in that the blood chemistry after treatment, they found interesting changes in lymphocyte metabolism and even gene expression, and also cytokine production. So what it indicated was there may well be a response that was towards connective tissue healing, and probably towards anti-inflammatory activity. And any of you who spend any time with this device, I have to say I can't help but believe anti-inflammatory activity is accurate. I've seen so many things working in burns and all sorts of different areas that it has to have some response in that way. Another one was results that came from a study done at University of Sydney, New South Wales, sorry, with Bill Walsh, and he did this in sheep and had a look at histologically at what was going on, and the main finding out of that, without showing you the slides, was a more organised structure in a very short space of time. So the kind of organised linear structure that you expect to see in tendons had actually begun to happen, and along with that changes in expression of the kinds of products that you require for developing tissue, blood tissue growth. So those sorts of things were significantly improved in those the sheep slides. And all of this, sorry, I think I've added that same one in there again. all of this led me to have an experiment. Now I apologise, this is my leg. This was done several years back and I've shown it to quite a few friends who are surgeons or who've done studies on tissue healing because it's just fascinated me. This was a bruise that I got about 8 days after I walloped the side of a table and collected my leg, and the centre part here was that kind of hard yellow core that you could actually feel really well in there, and then the outer area was obviously blood that was just sitting there and that it hadn't really changed over 7 or 8 days, even though I'd rubbed in Hiriador and used all sorts of cold packs and whatever I could think of. I then got one of the devices that you can get with the InterX, and I used it to massage the area and stimulate over about 10 minutes, and then I took another photo. And this was the change, so you can see that in 10 minutes there's a change in this tissue here, and then over 4 hours later you can see I am in focus, I'm not just a bad photographer. This appearance to the bruise was like someone had dropped water onto paint and it was spreading. It was actually dissipating and moving that dead blood out of the area. And then 20 hours later it looked like this. Now I don't know about any of you, but when I looked at that overall, I have never seen a bruise in less than 24 hours turn from that to that. And what it told me, even though this is incredibly anecdotal in a single case study, is that you must be increasing macrophage response. There's just no way you can't be. So at whatever level we are seeing changes happening and we are interacting with the nervous system and establishing some change in tissue. So that's the end of that little bit. Now I'd like to talk a bit about what we can actually do with it and who we can treat. So the kinds of conditions, most acute conditions respond really well, particularly those ones that are in an inflammatory stage. So rather than thinking of it as an anti-inflammatory device, what I tend to think of it as is a device that is optimizing the tissue response. And I'll often explain to people who are new to the device, if you injure yourself, say you've sprained your ankle and your body's responding to that, obviously it's sending in all the good products that are needed to heal the tissue, to help you support the tissue, and that comes out as swelling and bruising. You can see that you've done some damage. That response from your body is kind of like the first responders or the ambulance officers rocking up at the scene of an accident where your ankle injury is the accident. And what I believe we're doing with the InterX is we now uniquely have a way of dialing up the nervous system, talking to the nervous system and saying, it's great, you've sent 1 ambulance, well done, what we actually need here is 5, can you send us a whole lot more? And so we get this optimized response. We get a response that is trying to do what we already know the body's trying to do, but it's doing it at a much higher level. And that's why when you're looking at post-op pain, post-op changes, tissue changes, inflammatory changes, sprains and sports injuries, any of those things respond really well and really rapidly. And I would say, having used this myself post-op and knowing a number of people, even Bev as well, who've used it post-injury, there are plenty of opportunities to use it that I think people should start seriously giving consideration to. If we then look at chronic conditions, a lot of the things that we think of as, slow to heal or slow to change, like the non-responsive tendinoses, or, if you've got a long-standing lateral epicondylitis, your tennis or golfer's elbow, if you've got, a plantar fasciitis or an Achilles tendinopathy, all of those sorts of things probably have moved into a less inflammatory stage and into a more avascular, non-responsive kind of stage. Now, I can't tell you for sure why. Maybe it's partly because we're sort of stimulating the system to wake up and say, hang on, there's still something going on here we need to deal with. Maybe that's what it triggers, but we certainly see a response with these kinds of conditions with a more extended form of treatment, and I will go into those options, treatment options, very shortly. In addition to that though, I see a lot of people who have things like, neck pain or shoulder pain, lower back pain, because they're sitting and they're holding themselves very stationary for a long time, or they're doing a repetitive movement. So if they maybe have a particular way of getting out of bed because they've had a stroke and this is the only way they can do it, and then they start to feel soreness in a foot or a wrist or whatever, that's where we can really start to settle that back down again and give them back their freedom and their function, because we take away the issue that's now become a problem. And then we also see some conditions like scarring and Dupuytren's, certainly in burns, in adult burns in Perth. They use it fairly frequently for helping with scar tissue, and quite dramatic changes you can see depending on the person, but I won't go into that today. If anyone's got a particular interest in burns, that's one I can talk to you about separately. And one that I think that we really need to look at more and is of real interest is post-stroke pain, which is quite a common condition and often untreated, left untreated. People just assume that, you know, the main issue is the movement, when sometimes actually if you remove the pain and you allow someone to move pain-free, they'll extend themselves and try a bit further, or be confident to go further. So now what do we actually do? I just need to check how much time we've got, about 10 minutes, 15 minutes? Okay, so what do we actually do? When you apply the device, as you saw when I showed you the earlier video of placing the device onto the skin, you can drag the device across, and you've just got to make sure that your electrodes are placed nice and flat. And what you would do is choose your area of pain and then scan around the area. So we move at a fairly slow and steady pace, just moving through and scanning multiple streams, and I usually scan 2 or 3 along the one path, and then I'll move on and scan 2 or 3 along the next path. Oop, we seem to have something on screen. Oh, does that go out? Sorry. Am I back? Nope. How do I go back there? Sorry. Right, we're back here. Yeah, so scanning and then finding 3 to 5 active sites. Now the reason we're doing that is because we don't know, are we getting active acupuncture sites, are we getting trigger points, are we picking up these active sites? It doesn't really matter what we're picking up, but we want to pick up the most significant ones. So scanning through the area, you will find that the metal plate of the device grabs on the skin when the skin's moist, and you can do that with a teaspoon. If you get a teaspoon and you run it over your skin and you find an area where there's a bit of moisture, you'll find that it tends to grab in that area, and that's an area that we will consider significant and worth treating. But with the device we also get feedback through the numeric rating. So once I've found those 3 sites that I think are more significant, I would come around that area and I would just place the device on either side of it to make sure that I'm right in the middle of it, and my number being the highest will tell me that's where I need to treat. This is our process that we call scan and target. So once I've placed the device on there and I run it, the machine, the algorithm in the machine will identify how long I need to treat, and it'll give me then a yellow reading that's nice and easy. It tells me that's sufficient for that area, and I'll move on and I'll treat my next site and give each of those a treat. Now that takes probably a minute per site. So if we're talking 3 to 5 sites in an area, that may be 3 to 5 minutes worth of treatment, and that's all I've had to do for this scan and target. Then we go to what we call dynamic stimulation, and this I think is a critical part of it. Now I'm just going to branch off briefly to show you or talk to you more about this scanning and how you identify where to treat and how you can use these devices. So we've got 3 different techniques that we can use, and we're looking again for trigger points, nerve branches, acupuncture points, all of these areas of low impedance. We can find through a subjective technique where we slide across the skin, like I was saying, just dragging the flat electrode across the skin, feeling where it's sticky because there's moisture, and then asking the patient, and they'll often tell you there's where it's conducting more, where it's sticky, where it's the current can travel easily, they feel it a bit more. So you'll often get that from the patient. We also have an objective technique where we get these numbers on screen, and we go looking for our low impedance, and then we have what's called an automated technique. Now these devices, flexible arrays, are an incredible benefit and really add to your treatment options. You can strap them on around the area. Wherever the impedance is lowest, 2 adjacent electrodes will pick it up and the current will travel through that area. So really we've got this automated technique, and this is how it's being used particularly well post-op and immediate sort of post-sporting injury where you don't really need to think much. You put it on and you let it run. Now this dynamic stimulation then is what I was saying before. So dynamic stimulation is the third stage, and what we need to do is identify any of these things that create pain. So if palpation is enough to cause pain, then I would palpate and set it off, and I'd push with the device. In this instance, the patient's obviously doing a degree of resistive exercise and getting pain, and wherever that pain is where we want to stimulate. And they may also be able to do something that's functional activity or resistive exercise of this nature. It's really choosing what's appropriate to them. The keys here, the sensation needs to be stronger than the pain or stiffness, and we go for 1 minute cycles up to 5 minutes, and if the pain moves because they're not feeling it here now, they're feeling it here, we move with it and try again. This will produce really dramatic changes within 5 minutes. So now we're up to between 10 and 12 minutes of treatment total. So that's our dynamic stimulation. If we're not getting success immediately, we can extend the treatments and we go into areas further in the same dermatome to pick up any nerve spots in the dermatome that are relevant, or even at root level, spinal root level, which can be really effective, and we'd use that in really complex chronic conditions. I'm not going to talk about chronic complex conditions today because it's a whole other kettle of fish and really requires probably a full day workshop to do it justice so you can learn it. The things that you can look to using are different types of electrodes. So the actual handheld device can be used straight on the skin just as is, but you can also use the extensions that you've seen already, or one like this, which is a really large sort of handheld extension that you can just strap your hand to, and that's good for people who are going through large areas. You can use these flexible arrays, and the way they've designed them, the current only travels between adjacent electrodes. So that means that we can target areas that we really need to, but equally the back of these electrodes have a sort of piece that fits across that you can place this strap through, and you can put your fingers through the back of that and effectively use 3 fingers kind of as your pad that you can work with someone. Particularly if you're working with, say, someone who has a stroke or an injury where you need to stabilise them a little bit more, you can place the pad on and stabilise and stimulate all at the same time. Really quite an effective way of working. And then the last ones are some specialist electrodes. So we've got down here soft tissue electrode, which is used in this way, and a comb electrode. Now the comb is really more for, you can use it if you've got someone who's got, say, an arm that's particularly hairy, but you can also use it for a head, and that's quite effective when you're dealing with really complex chronic pain. But the one here that we tend to use in more acute conditions and early chronic conditions would be this soft tissue one. And you can see it here, when you place it on, you're really massaging through the tissue. So all of the things that, particularly I guess physios this was designed for, who tend to do a bit of soft tissue release, you can do that and use the nerve stim at the same time. So it's much more effective but much gentler on your hands. The device is designed to take that pressure out of the therapist's hands and at the same time provide the nerve stim. Really effective. And so when we get going with the device, really quick and simple, you can set the intensity, you place it on the patient, you get these readings on screen. It'll come up with, once you've chosen your reading, it'll come up with this screen which gives you your numbered reading and tells you what your nerve function is at the time, and then once you've treated for long enough, it'll come up with a yellow number in the same place. The main thing we need to reinforce here is we're looking for firm, comfortable tingling. We're not looking for prickling or stinging, but if there is prickling or stinging, it's not causing any harm, so the patient just tells us and we turn it down, and that's nice and easy. We do need to look at getting good skin contact, so you need to make sure it's flat. For any of you who are using it who sometimes say your patients are saying they're not comfortable with it, it's a little bit sharp. It may be that you've got the device on a slight angle and you're getting contact through a much smaller area and you want to even it out, so that's worth looking at. One thing I put in here briefly is making sure that you've got your guides aligned when you plug your device in so that you don't damage your pins as well. And also, when you're holding it, look for comfortable handling. Hold it in this area here. It's been designed in that way so you can really move it around easily without a lot of strain on your own hand. All of the settings are controlled through the navigation button here. So we come up with our acute, chronic and cyclic. Acute will give us a range of settings, and these are pulses per second or a variable rate of pulses per second. And then chronic obviously gives us a different one. Now this is a really quick last couple of minutes of how I choose my settings. So for those of you who are using it, this will be helpful for you. If you're going for acute, less than 6 weeks is what I would suggest usually, or chronic greater than 6 weeks. Some people will go for a month versus longer than a month, but you'll get this range of settings and options, and you can see the numbers here are a lot lower than they are here. Now the way I describe that most times to people is if we're thinking of this as having a conversation with the nervous system, we're kind of wanting acute conditions which are fairly new, fairly young, fairly able to cope with, you know, loud noise and stuff. It's like putting on a radio station that is, you know, loud, amped up. We're talking, you know, heavy metal, that kind of music. Whereas a chronic condition, and particularly a complex chronic condition like CRPS, complex regional pain syndrome, we really need to have a gentle conversation, and we need to have that classic easy listening radio station instead. So that's how I would suggest you choose it. If you're thinking about your clinical reasoning, go with that. It's not happy. Oh, here we are. So we've got settings that you can choose. To make it easy, I tell people go with 360 for acute, 60 for chronic, so you've got those numbers that match up and make your life easy. But then you've got some other, I guess, outliers that you can pick other options for. So if we're talking really early post-op, you can even go up to 480. Really have a loud conversation with that nervous system and tell it, yep, pack it in, we need to move on here. Whereas a really chronic complex condition or a hypersensitive system, a system that's on overload already, does not need loud conversation. It needs gentle treatment, so 15 is better. And then if we look at the stage where we go into dynamic treatment, we need to move into variable settings. So this is effectively like varying our conversation. We're changing backwards and forwards. We're making it more interesting. We're going to get more of a response out of the nervous system. So in all acute, I go with 90 to 360. In most chronic, I go for 30 to 120. But in complex chronic, I'll go to 15 to 60. Okay, so it just gives you a way of clinically reasoning what it is that you need to go for those kinds of patients. We've already had a quick look at the screen. I just mentioned here, don't be too worried about any of these. This is your pulses per second you've chosen. This is the intensity. Now, the intensity doesn't really matter. Some patients will say, oh, last time I was up to 80%, now I'm only at 20. That's irrelevant. It's based on the impedance at the time. If they've been out and running, their moisture might be greater overall, so those numbers will change. And really what you want to go for is that sensation, comfortable, subnoxious, maximal, without pain, that kind of thing, all right? And then don't worry about these ones. If you ever want to do a more complex workshop, we will discuss those in more detail. And then I'd just like to point out that yes, you can treat complex conditions, but with care. These are nervous systems that have had a hell of a lot of pressure. They're really not coping well with a lot of conversations, so you want to make sure you're very gentle on them, and I would suggest that you hold back on those. Now I think that may be where I was pausing it, leaving it, and Bev tells me we've got about 5 minutes for some discussion, so we might try.
We've got a couple of questions that have come through. We've got a comment from Pat Hughes. She's an OT from Toowoomba. Hi, Pat. I use the InterX every day with my clients with amazing results. When it's coupled with mental health approaches and meaningful occupation, the results are astonishing. I'm thrilled to be a pain therapist practitioner. Well done.
That's fantastic to hear, Pat. I just love too that you've put in there the fact that you use it with all the other methods as well, because I just think anyone who's listening who hasn't spent any time understanding pain, that would be my first point. If you go even to the Explain Pain workshops that Lorimer Mosley and David Butler do from South Australia, you will immediately start to recognise why we're having a conversation with the nervous system and how we can do it. So Pat, you've obviously got some really good clinical reasoning going on there by the sound of it.
Got another question from Matt Beaumont. Is the localised responses in acute inflammatory responses similar in chronic conditions?
No, the response changes. There's some quite good literature out there that talks about how the response changes, but it's not really thoroughly known yet, and I think it's an evolving, moving target at the moment. What I would say though is, if you look at how you use your InterX and you really stick to that idea that when I'm talking to the nervous system, if I'm loud and obnoxious and I'm saying back off, back down, change this, change that, and being really bossy, the acute conditions can cope with that, but once we move into a more chronic phase, we need to change what we're doing. So when I treat, I would try what I think is appropriate, and I'd keep to a very short treatment, say an epicondylitis or a plantar fasciitis. I would treat quite locally if it's acute conditions, and further away if it's not. I'd go gently around the area. And then I would see how they responded when they came in the next time before deciding whether to keep going down that path or whether to try a different path. But we probably need to do another workshop to get more into those kind of chronic conditions and to get the best out of them.
We have a question from Jordan. I note the studies presented seem to provide treatment frequency of two times 20 minutes per day for several days. In a clinical setting, this is not usually possible. Are there still benefits in using the InterX less frequently, say once per week?
Absolutely. Depending on the condition, but also one of the best options you can have, if you use it as a clinical tool, you'll probably use all of that kit. And I think I've got a few photos that I loaded. Oop, it's not happy. Can I change that, Bev? Sorry, down there. So, sorry, that was my stuff about pain paradigms. Oh, I think I've chucked in, there's some nice photos of me, my wrist, so in case anyone had any questions. I just wanted to show you these here. So using the pads and using a smaller device, this one here is the InterX 900, which has recently been released in America, and it's been released with these kind of protocols so people can use them post-op, and a garment that you can just set the pads in and let them run. People can actually treat themselves, and you would do an adjunct treatment, so you would see them once a week, but in between times they could treat themselves with one of these simpler devices. And I'm not sure yet where the Rear Care is offering that.
Yeah, so you can rent devices for your patient through Rear Care, and then they're able to do their treatments at home and then see you on that once a week to re-evaluate.
Yep. And you can see here, really simple, these are the controls that the patient will see. This allows them to change their setting from acute 1 or 2 or chronic 1 or 2, depending on what you tell them you want, and then all they're doing is turning it up. So you're telling them what radio station, and they're turning the volume up.
So here locally we'll have the 1000,
okay.
The personal 1000 device.
Yep.
We've got one more comment from Mandy Hughes. Katrina, great talk. Thanks, Mandy.
Thank you, Mandy. Appreciate that. It'll be good to catch up with you sometime.
If anyone has any more questions, send them through. We've just got a couple of minutes now, but if not, feel free to contact Harish, contact Rear Care for further inquiries or further information. And then we will then probably look at scheduling another webinar that will focus more on chronic conditions, in greater depth. It doesn't seem like there's any more questions coming through. Oh, hang on, sorry, spoke too soon. There's a question here. Let me just get to it. Do you set the percentage of stimulation to that just tolerable by the patient when you are looking for the active sites to treat, or at a comfortable level of stimulation? Which is best?
Yep.
Mandy.
That's a really good question. I set it at a comfortable level to start off with, because when you're moving it around and you suddenly run over the top of one of these active sites, if it's too intense and they're not used to it and it's their first time coming in, they'll often react quite strongly to it and they find that quite offensive, and you can damage your trust with them. So I tend to set it at a comfortable level where I know that I'll get to hear from them if they're feeling it. I'll get to, you know, find what's going on, but I'm not going to get them overreacting. And then once I've found that site, I readjust that level to make sure we're getting a good strong sensation. And in an acute condition, far stronger, you want to go for that really strong, just subnoxious. Whereas with a chronic condition, you can probably back it off a little and go a much gentler sensation, but still something that they can feel, because we need that.
Okay, thank you. We've got another question from Jennifer. You mentioned OA. How would you treat EG and knee?
Okay, so OA obviously being a chronic condition, I would first of all take some judgment as to whether it's just a chronic OA or whether we've got some elements of a more complex, you know, hypersensitive situation. And if there was any doubt at all, I would start on much lower settings like the 15 to 60 and using 15 for scanning. But then I would go scanning around the area fairly broadly. You probably need to come up to mid-thigh and down to mid-calf to start off with, and just find what I'm getting in terms of active sites and treat those, and then get them to do just some very gentle walking, sitting, moving, whatever it is that sets off the pain, I'll get them to do with the pads on and let it run for 10 minutes. And I'll keep to a really simple treatment like that for the first time, and I will warn them that it may set off their pain the first time, but that they need to keep feeding back to me and let me know how they're going. Sometimes with chronic conditions, they'll first of all, they won't necessarily notice a change in their pain or a reduction in their pain, but they might notice that they're more comfortable moving, like walking, or that they're less aware of it, or that they sleep a little bit better maybe. They're all kind of things that sit around the problem, and it might take quite a few weeks, probably at least 3 to 6 weeks, to get shifts that you can then definitely say we know what path we're going on, and you just modify as you go over that period. I hope that's what you're looking for.
We've just got one more, a couple more, and then we might then bring it to a close. Just a comment from Matt Beaumont, excellent work team, looking forward to the chronic treatment webinar.
Brilliant.
And then just one from Fiona. Sorry Fiona, but you seem to have experienced some problems with audio, which was distorted in the last minute. I know that ReaCare are recording the presentation, so we'll make that available to everyone, and hopefully then the sound will be much more perfect and you'll be able to hear the webinar again. I just want to close by thank you Katrina. Thank you Katrina for your brilliant talk. I think it sort of dumbs it down and makes it very
accessible, hopefully.
Yeah, accessible, and explains a lot of the features of the device and how pain is treated using the InterX. I also want to just thank everyone for their time. I know it's late over there, wherever you are, or but after a long day's work, it's sort of sometimes very hard to get on a webinar. So thanks so much, everyone, for your time. Appreciate it. Just sing out if you have any questions. Just contact ReaCare, and we'll chat again soon. Thank you.
Thank you all. Bye.
Bye.